So I want to kick off with what I mentioned earlier about that illness system, because you've described Australia as having that kind of illness system rather than a true health system that's promoting wellness. This idea obviously isn't new. A lot of economists have talked about it. When you're talking about an illness system, what do you mean? And I guess what are the underlying features or incentives that are making our system focused on illness rather than health and wellness?
Yeah, for sure. And I'm certainly not the first one to point this out, but I think what's changed is that it's quite clear that our entire health system or healthcare system seems to be under stress now constantly. Public hospitals, primary care, and as we've seen in the private sector as well. So what I mean by this is that our system is unbalanced and too reliant on hospitals and specialists. So on treating people who are ill instead of trying to keep those people healthy or managing their illness at an earlier stage. So our model worked last century, but it's starting to fail as our health needs are changing and our expectations, to be honest, as a community. And I think we're starting to pay the price. The data paint a pretty clear picture. For example, in Australia, the gap between our healthy lifespan and our total lifespan is 12 years. That's 14% of our lives, and that's the second highest gap in the world behind the USA, which is not a league table we want to be at the top of. But also, there's other data. So our amenable mortality after things like stroke or AMI or heart attack is exceptional. We're one of the best in the world, but our avoidable hospitalization rates are 30% above the OECD average. And this is, according to the AIHW, costing us about $7.7 billion a year. So we're excellent at rescue. We have brilliant acute care. We have world-class clinicians, but the incentives we have push the system to treat disease rather than construct health and build health before it gets, I guess, to a point where people need interventions like surgery and so on. So our chronic disease risk factors are amongst the highest, like obesity. Our cancer incidence is, according to the OECD, the highest in the world in the OECD, but our cancer mortality is around the average. The only bright point really is our smoking rates, which are comparatively low, and I think we all know why that is. And then when we look at spending, we're about 1 percentage point above the OECD average, 10.3% of our GDP versus 9.3%. But the amount our government spends on health is the fourth highest in the OECD. So we spend 20% of our government expenditure goes on health services, but our spend on prevention is comparatively low. And we have a lot of MRI scanners and PET scanners per capita. We have higher than average doctors per capita, but we have a GP shortage. So that tells us something about where that workforce is located. And when you look at AIHW data, again, what we spend on acute care, so hospitals and specialists, is growing faster than what we spend on primary care. So from that, it's not hard. It's not hard to surmise that we let people fall ill before we intervene. And so we've parked the ambulance at the bottom of the mountain, and we're waiting for people to fall down the mountain rather than putting in better guardrails and safety measures up there. So sure, some people will fall. So we'll always need an ambulance. We'll always need hospitals. We'll always need specialists, but it can't be what we principally rely on. It's expensive and inefficient. It's quite insane when you really think about it. And it certainly isn't sustainable medically or financially. So the medical technology at the moment is just unbelievable, but it's also priced very highly. And I think this the combined effect is why we're having all of these problems across our health system. And putting all this together, we're starting to look like the US, which also has a very acute laden system. And the reasons, really, the direct reasons is, there's several factors, but, prevention is hard. It's hard to sell and it's hard to monetize, and it isn't sexy. So it's much easier to open a hospital, cut a ribbon, than to announce something like a sugar tax. Prevention is also hard to measure. And so we measure success poorly and often not at all. So we're good at tracking inputs like beds, waiting times, but not really outcomes, and both outcomes of care. So patient-reported outcome measures, for example, which I know you've championed, and but also outcomes of prevention. So the amount of disease avoided. So it's the fragmented system we have doesn't help. So it's been described as a bit of a marble cake. It's very complex to navigate for patients, and it's also very complex for policymakers. So no one really owns population health outcomes in our system. And we've let illness become the economic engine. We reward activity and volume as opposed to outcomes. I think they're the main reasons why we found ourselves in this situation.
Hey, if you like this clip, hit the like button or leave a comment below. It really helps more people discover the show.
That's right. And if you want to stream the full uncut episode, visit our website at amplieo.com.
Thanks for watching and supporting the future of independent media.